Good afternoon and welcome. My name is Aida. On behalf of the Division of Healthcare Financing and Policy, I would like to call the meeting to order and verify that today's meeting agenda for the Public Option Design Session 4 was posted on January 6, 2022 on dhhs.nv.gov and at notice.nv.gov. I will now turn it over to Emma at Manat to go over some housekeeping items.
Live closed captioning will be available during today's meeting. Click CC on the bottom of your Zoom window to enable or disable. There are a few ways attendees may participate today. First, participants may submit written comments and questions through the Q&A box. All comments will be recorded and reviewed by the state. Participants may also submit comments and questions to NV Public Option at dhhs.nv.gov. At designated times, spoken comment will be permitted. Participants must raise their hand for Zoom facilitators to unmute them to share comments. The facilitators will notify participants of appropriate times to volunteer feedback. If you logged in via phone only, press *9 on your phone to raise your hand. Listen for your number to be called, and if selected to share your comment, please ensure you are unmuted on your phone by pressing *6. If you logged in via the Zoom interface, press raise hand in the reactions area, and if selected to share your comment, you'll receive a request to unmute. Please ensure you accept before speaking. Public comment will be taken during the meeting at designated times. Individuals will be called on in the order in which their hands were raised and will be given 3 minutes. Please state your name and organizational affiliation when you begin. Participants are also encouraged to use the Q&A to ensure all feedback is captured, or again, you may email comments to nvpublicoption@dhhs.nv.gov. The state will publish a public option FAQ and will continue to use this resource to inform the public and address design questions. And with that, I'll pass it to Suzanne Bierman.
Great, thanks, Emma. Good afternoon, and thank you all for participating in today's design session stakeholder meeting. During today's meeting, we will cover the following topics: benefits, value-based payment and cost containment strategies, next steps, and public comment. Next slide, please. Next slide, please. Thank you. Here we have the design schedule, the design session schedule. It provides an overview of the topics that will be covered today, as well as in previous meetings, and also provides a preview of the topics in the sessions yet to come. Following today's meeting, there will be 2 additional design session meetings. Next week, on January 18th, we will discuss rate setting and rate review, provider contracting and networks, as well as potential strategies to strengthen the marketplace. The following meeting on January 28th will cover licensure and oversight, discussion on potentially offering the public option in the small group market, and an overview of the next steps in the public option implementation, including an overview of additional opportunities for stakeholder input, actuarial analysis, and the waiver development process. I want to note here that we will also continue to accept public comment outside of the design session meetings, and you may do that by submitting written comments to nvpublicoption@dhhs.nv.gov. I encourage participation in the upcoming design sessions, joining the listserv, and monitoring the public option website for ongoing updates. Next slide, please. Okay. This slide presents an overview of today's goals, and here we will review the objectives of today's meeting in greater detail. In today's presentation, we'll present information and pose questions for stakeholder feedback related to benefits, such as questions that we would love public feedback on include what is most needed to ensure that enrollees have access to the care they need, a discussion around potential additional covered benefits for the public option plans, thoughts around reducing cost sharing for certain benefits, and as well as ideas about expanding access to providers. In addition to the benefits conversation, we will also talk about value-based payment and cost containment strategies. Some of the questions that we'll tee up and would like feedback on related to those topics include how the state could align its purchasing strategies, cost controls, and value-based care between the Medicaid managed care organizations and the exchange plans. Additionally, I'm interested in feedback on whether there are provider contracting and value-based care opportunities that would promote the goals of improving equity, access, and culturally competent care. Are there successful models that we should note and incorporate as we consider these decisions? Next slide, please. Oh, here, I think I hand the presentation over to Ann Carl from Manat. So Ann, thank you.
Hi there. So we wanted to solicit input from the public on the level of benefits that would be offered in the public option. So there is a requirement that the public option be a qualified health plan, and qualified health plans must cover essential health benefits. Essential health benefits are defined from the benefit packages of different reference plans. States have some flexibility to mix and match those EHBs from reference plan options to create a more robust benefit package. We list here what the 10 EHB categories are. And again, within each of those categories, exactly what it means, for example, for rehabilitative and habilitative services and devices is defined by looking at what rehabilitative and habilitative services and devices are covered in the reference plan that was selected. So we wanted to just flag also that to the extent that there is some, that a plan is offering something that is not an EHB, that cannot be covered with the premium tax credits and needs to be covered separately by the individual, or the state could provide additional support to cover those costs. So one of the questions that we have for stakeholders is whether there are any additional benefits the public option should include: care coordination, dental care for adults, more extensive coverage for behavioral health services, again, recognizing that some of those services may require the state to fund and therefore may be cost prohibitive, whereas other services may be able to be included by making some modifications to the EHB definition by looking to other reference plan options for perhaps more comprehensive scope of services. On the next slide, we focus specifically on mental health benefits. So QHPs must cover mental health and substance use disorder services. And there's an inpatient minimum of covering SUD services of at least $9,000. And we, in addition to these services that are covered here generally, we wanted to know whether there are issues with access to care. We've heard that sort of consistently throughout these design sessions, that there are challenges accessing to care, and we think that is probably particularly true with respect to behavioral health services, so we would welcome input on that. We also would welcome input on affordability challenges. So are there particular cost sharing or deductibles that wind up being prohibitive, that even if someone could get an appointment, they feel as though they can't use that? And then the last question is, are there any benefits that in the experience of those who are at this session feel are not covered under QHPs today, but would be beneficial to consider including in the public option, whether as an expansion to the definition of EHB or as potentially a state-funded benefit? So with that, I will turn it over to Stacey Weeks and Marie Zimmerman.
Thanks, Ann. Okay, so let's talk a little bit about the use of value-based purchasing or payment design in the public option. And when we talk about value-based payment, you might have also heard it referred to as alternative payment models, or there's kind of lots of different names for it. What we're referring to is a shift in how we pay for healthcare. This shift is from a traditional fee-based provider payment arrangement to one that is focused more on linking the provider payment to value. And value can mean a number of things. It can mean improved quality of care, patient outcomes, provider performance, et cetera. In the establishing legislation for the public option, the director of DHHS is required to encourage the use of value-based purchasing or payment design by carriers. The state, though, has discretion in how it wants to achieve this goal. For example, the director has the discretion to define the types of value-based payment programs. that carriers will use with providers and their networks. And it also can design a glide path for increasing capacity for the state's healthcare system to participate in more advanced payment models that focus on rewarding and paying based on value. There are a few considerations we wanted to note before kind of diving into the conversation about the use of value-based payment with the public option. The first is it could be a useful tool for carriers and the system in controlling costs. So cost containment is a big piece, as well as improving health outcomes. Carriers can also use these types of payment designs with the provider networks across what is known as multiple products or multiple product contracts. This could be across Medicaid and the public option. The success of these programs rely, though, heavily on the capacity and the capability of the state's healthcare system. So this is an important consideration over the next 4 years before the rollout of the public option in the market. Incentive payments to providers can be, though, a helpful tool in building that capacity, but they must be generous enough to motivate providers to invest in new approaches to care without subjecting them to unmanageable risk. So these are just important things to think about as we talk more about these models. Next slide, please. So when we look at Nevada's experience in using value-based payment design, there has been some movement over the last 5 years to move more in the direction of using or paying providers for value. This has occurred mostly, though, in the state's managed care program, as you can see here on the slide. In its most recent contracts, the state is requiring managed care carriers to begin to adopt these types of payment models with their provider networks. The new contracts also allow the state to require provider contracting to reach specific milestones with respect to these new payment models each year. It also allows the state, if it chooses, to impose penalties, financial penalties on carriers who do not meet these targets with their provider networks. Suzanne, is there anything on this slide you want to add before we move on?
No, Stacey, I think you did a great job. Thanks.
Okay. Next slide, please. All right, so this chart here provides a framework for how we want to think about value-based payment, or APMs. This chart was developed with CMS and by CMS with a group of private and public stakeholders. It also included health carriers and providers nationally. This framework provides states with a common language to use when thinking about implementing new payment models over time and to measure how these new models are evolving or changing in the state. On the left side, we start with what we think of today as our traditional provider fee-for-service payment, which is based purely mostly on how many procedures you deliver is how much you get paid. Moving from this payment arrangement across the continuum here to the right, we begin to see other types of payments that are linked to quality and value. These can include early on with providers incentive payments or bonus payments, for example, and helping providers achieve certain metrics or outcomes and rewarding them for that, or incentivizing, and also helping improve their capacity to participate later on in more advanced models. And as you get closer to the farther right of this chart, you'll see that there's what you might think of those more mature or advanced models where there's greater, where providers and carriers are sharing the financial risk and reward for the population and for payment. Again, though, this is just a framework. It's important to note that not all providers will or should fall into every payment arrangement here and all these columns or even over time. It's more of just a tool to help guide states and policymakers in the conversation about. And as we think about how we want to reshape how the state pays for healthcare based more on the value and the outcomes and less on the volume. Next slide. I'm going to turn it over to Marie on my team. Marie?
Great. Thanks, Stacey. That provides a great overview of some of the foundational work in value-based care purchasing that Nevada already has underway to build upon as the state and the community thinks about how it might further these efforts prior to and after the public option being implemented. I think the good news is that Nevada has quite a bit of time prior to the implementation of the public option for readiness, and it can create a roadmap over the next several years of how the public option, also Medicaid, and even potentially other parts of the market can align their VBP efforts. As alignment, we have found across payers is often key to provider participation and sustainability. So as Nevada thinks about how to further its VBP efforts, so value-based purchasing, and design for the public option, as well as potentially Medicaid, it has options on how to approach a VBP program and framework. These could be options where the state is directing the specifics of the model. So for example, and some of these options, this is on the left-hand side of the slide, come from other states and or CMS. The state could direct plans to pay primary care providers a per member per month amount for care coordination, care management, population health, or to expand capacity and hours of primary care so people can get their care needs met in a less expensive setting. So an example of this is actually in the state that I live in Minnesota, where they pay providers this way, and the providers can use this funding flexibly, even on things like social determinants of health. And the payment is also adjusted based on the health status of enrollees and also some of their social risk factors, such as them having food insecurity. The state can also consider models that focus on maintaining and building access to healthcare in rural areas of Nevada. And one example of that comes from the state of Pennsylvania, where they have a rural health model that pays a global budget to hospitals to ensure that they have a sustainable financing model to maintain access for critical services. And just one example of that tends to be something like maternity care. That's something that is expensive for rural hospitals to maintain, especially when there's lower numbers, but it's such an important thing for folks in rural areas to have access to. Nevada can also consider plan-led approaches as well, where the state can put in place a broader requirement or framework, and then the health plans develop the details of those arrangements with providers. This is somewhat similar to how what the state has in place for its Medicaid plans today. So for example, the state can set specific targets for plans to have VBP arrangements in each of those land categories that Stacey just reviewed on the last slide. So for example, the state could say, by the third year of the public option, 50% of provider payments should be in a value-based arrangement. And Nevada can also further consider, saying what percentage within those arrangements need to be risk-based, meaning that providers and plans are engaged in arrangement that include financial risk for meeting certain cost and quality targets. So these are just some examples of what could be done, and the state is looking for input both on the approach, meaning how directive and specific to be with its VBP program, but also other payment reforms that the state should consider as part of this. Next slide. And so to wrap up the discussion on value-based purchasing, the state is also looking for public input on, are there other approaches that should be considered for the public option that can improve outcomes while containing costs, particularly that would align with the recent governor's executive order on cost growth in Nevada's healthcare system? And then also, is there other information the state should think about in considering value-based purchasing design for the public option, but also potentially in alignment with Medicaid, particularly to support the transition, support providers and the transition of providers to value-based purchasing? I just want to pause there and see if Suzanne wants to add anything to that.
Thanks, Marie. I don't have anything to add. I think you did a really comprehensive job, and thank you.
And I will kick it back to Stacey, I believe.
Yep, thanks, Marie. Next slide. Okay, we're going to dive into next steps. Next slide. So before we start public comment, just a few reminders to visit the public option webpage for regular updates. There's the address there, and also please feel free, as always, to submit questions or comments to the inbox here, the address you can see. The next design session is on January 18th from 12 to 1 p.m. Pacific time. This session will focus on health plan rate setting, rate review, provider contracting, network adequacy, and strengthening the individual and small group markets. But again, like Suzanne has said before, you can submit comments on any of the topics we've discussed over the, or anything you would like to discuss at any time. Thank you. And I think I'll kick it over to Emma. I think we're going to start public comment.
Thanks, Stacey. I see a few hands raised, so we'll start with Helen Foley. Helen, you should be able to unmute now, and 3 minutes will begin.
Great, thank you. Good afternoon. This is Helen Foley representing the Nevada Association of Health Plans. We are submitting a little bit later this afternoon a letter from the association that addresses the questions proposed for this stakeholder meeting, but I wanted to highlight them for you right now. Regarding the benefits, as we mentioned last meeting, there's a direct correlation between benefits and premiums. Incremental services above and beyond essential health benefits would increase premiums and create selection issues between standard and non-standard plans. If the goal is to offer a premium that is below what is currently available in the marketplace, offering services or benefits beyond what is available will more than likely be counter to that goal. That is why we recommend limiting covered benefits to the essential health benefits in the benchmark plan. Regarding the value-based payment and cost containment, insurers should be encouraged to develop alternative provider payment methodologies that encourage providers to render high quality care, including high value services as a means of cultivating overall health and well-being for Nevadans. Additionally, we support the right care at the right place and at the right time. This is in the interest of ensuring high quality care access at an affordable premium. We've provided examples for each of these in our letter, and we thank you very much.
Thank you for your comment. Next up, we've got Barry Gold. Barry, you should be able to unmute.
Yes, thank you. For the record, my name is Barry Gold. I'm the Director of Government Relations for AARP Nevada. I'd like to address one of the benefits that is critical to include, and that involves family caregivers. Family caregivers are often a critical part of the care plan and care coordination. Often they might be included in care planning. However, they also do a lot of care for the patient as well. Now, I understand the public option is not long-term care insurance as such, but these unpaid family caregivers often are performing complex medical tasks for which they have absolutely no training. So it's really important that we consider including caregiver support and caregiver training in any benefits that we do, because they often can reduce costs and prevent people from going back to the hospital doing something else, whether it be feeding tubes, complex medication, or diabetic care. These caregivers need some training and they need some support in what they are going to do. I know that the aging division is looking into caregiver assessment as part of the process. And that's another part that kind of goes into caregiver support, is caregiver assessment. You have these caregivers who are doing lots and lots of things, taking care of the patient. However, sometimes somebody needs to look at what is going on with them and how well are they able to do the job. And I guess that falls into what kind of support and training do they need. So AARP, on behalf of our 345,000 members across the state, strongly urge that caregiver support and caregiver training be included in the benefits. Thank you.
Thank you for your comment. Next up is Eric Jang. Eric, you should be able to unmute now.
Thank you, and hello everyone. My name is Eric Jang. I represent One API in Nevada, a community advocacy group for the Asian and Pacific Islander for Nevada. Thank you for this stakeholder discussion on benefits and payments and cost containment. Value-based payment designs are the fundamental change our healthcare systems needs to not only bring down the growth in healthcare costs in our state, but also to refocus our healthcare system on prioritizing patient health outcomes. This includes changing how we pay for and promote early and preventive interventions, in addition to outpatient and aftercare services. Our partner organization, the Asian Community Development Council, is starting out our own community health clinic to address some of the issues. And this is an important partnership that we want to continue instead of having to resort to higher cost inpatient emergency care for what should be a routine clinic visit, or to wait until conditions have worsened into emergency situations. Nevadans should be able to get timely care in more appropriate primary care and outpatient settings. By design, this means better outcomes and lower overall costs for our healthcare system. Unfortunately, lowering emergency visits also means less revenue for most large healthcare systems. Therefore, redirecting the business model in a way that rewards and does not penalize providers in healthcare systems is key. Providers and hospitals willing to work toward a healthcare system that places more value on outcomes should also be able to take on more risk and be rewarded in these instances when outcomes and quality are improved in the healthcare systems. These types of rewards and risk are the premise of value-based payments. So in order for providers to succeed and to be sustainable in these new models, we encourage the state to find opportunities to build the capacity of our state's healthcare system, generally with respect to primary care and outpatient workforce. This includes helping our state diversify its workforce, things like increasing reimbursement rates for primary care and behavioral health services, generally in Medicaid or by directing plans, and the public option to provide incentives or bonus payments for systems willing to invest in expanding these service lines. Other ideas worth considering for building our workforce capacity, including loan repayment for providers that move to Nevada and work in fields like primary care, mental, behavioral, and substance abuse and medicine and urgent care. The new reimbursement structure that over the long term prioritizes improvements in quality and patient outcomes instead of profit-centered fee-based care. One thought that we have is to find a way to use some of the American Rescue Plan, so ARPA dollars now to build up our primary care and outpatient care capacity, and then use dollars from the public option trust fund dollars in the out years to continue these types of incentive programs as the rescue plan dollar fall off. By using ARPA funds up front now to build capacity in primary behavioral and addiction medicine, we can lower healthcare costs in the host system and improve individual Nevadans' medical outcomes. We can also better equip our provider system to take on more mature and meaningful value-based payment designed in future years. So to conclude, we need a healthcare system where Nevadans' point of care is a primary care provider and a system that includes urgent or after care hours for patients who do not need higher cost emergency cares. Also includes an accessible outpatient behavioral health services system that can help people avoid more intensive and costly therapy and treatment down the road. Relying primarily on on emergency room and inpatient setting is not only not quality care, but it is unsustainable in terms of cost. So the public option and public option trust fund is an excellent opportunity to think outside the box and build the capacity our state desperately needs, not just to bring down healthcare costs, but to improve patient outcomes. Hopefully I got that in time. Thank you so much for your time.
Thank you for your comment. Next up, we have Stacey Sasso. Stacey, you should be able to unmute now.
Hi, this is Stacey Sasso, Executive Director for the Health Services Coalition. The Health Services Coalition continues to remain concerned and cautious of the public option offering an impact to both our 25 member groups as well as the community as a whole. We'll continue to work with internal resources to fully understand the impact and unintended consequences of this legislation on our plans, and we will share those results with you when completed. In addition, we would request that all comments and reports submitted by stakeholders be shared publicly, and we appreciate the stakeholder comment process and look forward to additional opportunities to work with you.
Thank you for your comment. At this time, it does not look like we have any other hands raised. I saw one come up for a moment, but it went away. Okay, I think we can wrap up public comment.
Okay, thanks, Emma. Thank everyone for your participation today, and we look forward to the upcoming 2 stakeholder meetings later in January. Thank you all.
Well, you know what, I just want to flag, I'm sorry to interrupt. We did have a person who is interested in unmuting. They're on the phone, but I don't see the hand raised. So I'm just gonna, that would be Patrick Kelly. Patrick Kelly, I've given you permission to speak. Are you able to unmute? I'm not able to hear you, Patrick. If you are able to hit *6 on your phone, you should be able to unmute. All right.
Can you hear me now?
Yes, we can, Patrick. Thank you.
I'm sorry, I have an unstable internet connection. Hang on. Good afternoon. My name is Patrick Kelly, and I'm the CEO of the Nevada Hospital Association. As we proceed with these design sessions, more questions arise than answers. It's becoming increasingly difficult to provide meaningful comment when we aren't receiving any feedback. I hope feedback from the state is part of the process going forward. The actuary will need the position of the state on several key issues before moving forward. With respect to today's topics, we have a few questions. How will the state ensure a robust provider network with the stated premium reduction? How will financial equity be achieved between health plans and providers? Will the margins for each group are reimbursed fairly? What mechanisms will be put in place to prevent Medicare rates from becoming the reimbursement ceiling? How will the state use value-based care to improve equity, access, and culturally competent care? Additionally, I'd like to address the cost containment today. Several factors drive cost in healthcare. Labor is a major factor, and that cost has exploded. Healthcare facilities are paying exorbitant rates to agencies for traveling nurses. The state can reduce this cost by taking meaningful action to educate more nurses and techs of all kinds. We've known for more than a decade that Nevada has an inadequate supply of nurses. Now it's time to do something about it. Graduating more nurses will help the economy, help the people of the state. Another driver of healthcare cost is the health and lifestyle of the people insured. If we want to improve the health of the uninsured, we need to add creative and innovative programs to prevent people from getting sick or developing chronic health conditions. The state to include population health initiatives as a major component of cost containment. Thank you.
Thank you for your comment. There were a few moments when we did lose a few words. So Patrick, I encourage you to submit your comment through the email as well. And we will now unmute Brittany Jacobs. Brittany, you should be able to unmute at this time.
Hello, my name is Brittany Jacobs, and I'm just a member of the community. I've been following along with this because of the healthcare costs that I incur. Currently, for my family of 4, we pay about $800 a month, and my premiums are sky high, right around $7,000 per each member of my family until we are covered at an 80-20%. My biggest concern, because I am a type 1 diabetic, is obviously insulin, which can run me $900 to $1,000 a month. Is really focusing on the monthly premium that I pay every month, which for my family is about $800 per month for 4 members, plus the access to care during that time until my premiums are met. So I think that really needs to be addressed. Thank you.
Thank you for your comment. Okay. At this time, I do not see any further hands raised.
Great. Thanks, Emma. So again, thanks everyone for your participation today, and we look forward to our upcoming stakeholder meetings in January. Thank you.